नमस्कार. प्रुडेंट मिडियाच्या गजाली ह्या कार्यावळीन तुमकां सगळ्यांक येवकार. आयच्या गजाली ह्या कार्यावळीन आमचे बरोबर आसात डॉक्टर कल्लूर के.जी., डायरेक्टर मॉलिक्युलर इमेजिंग फ्रॉम HCG हॉस्पिटल बेंगलोर. आणि आयचो जो विशय आसा तो म्हणजे सर्वसामान्यपणे हो सगळ्यांच्या मतीन येवपा सारको असो विशय न्हय. कारण हे जे कन्सेप्ट आसा किंवा मॉलिक्युलर इमेजिंग हो आसा हे टोटली न्यू, स्पेशली इन कंट्री लायक इंडिया म्हणजे भारता सारक्या देशांत हे सामकें नवें अर्विल्लें तंत्रगिन्यान अशें म्हणूं येता. आयच्या कार्यावळीच्या माध्यमांतल्यान आमी एका नव्या तंत्रगिन्यानाची वैजकी मळाव्या एका नव्या आविष्काराची तुमकां वळख करून दिवंक सोदतात आनी आमचे बरोबर आसात डॉक्टर कल्लूर. डॉक्टर कल्लूर, नमस्कार, वेलकम. बेसिकली इफ आय एम नॉट रॉंग, molecular imaging is something totally new, at least in a country like India. So everybody is eager to know what is this molecular imaging, because every time we have till date we have heard of, we started from plain X-rays, we went to ultrasound, we went to CT scan, we went to MRI, then PET scan. So what is this molecular imaging and how different it is from all traditional and all the other methodologies which were followed till date?
The molecular imaging is actually a new modality. What we do is use isotope. Earlier it was called as nuclear medicine. Most of the centers today, even also it is nuclear medicine, we use isotopes. They are used for, it is one of the most peaceful uses of radiation for diagnosing many illnesses, and also it is going to be used for therapy also. We have seen the destructive force of the nuclear energy, which you might have all heard in Hiroshima. Nagasaki, but we are using this radiation for diagnostic purpose as well as for therapy purpose. In molecular imaging, we use predominantly for a diagnostic purpose in our country. At least 80-90% of our work revolves around the diagnostic work only. Many centers it is called as nuclear medicine. It is being called as molecular imaging in future because we can diagnose disease at a molecular level. Even we can diagnose it even before any structural changes happen. That's why we are going to call it as a molecular imaging.
I see.
You might have seen many earlier called isotopes, called isotopic scans, called as a bone scan, thyroid scan, as well as the PET scan. They are all actually the isotopic scans, nuclear scans only. But now in future it is going to be called as molecular imaging. Also it may be a new branch of medicine might emerge called as anatometabolic imaging. What we do is we use isotopes, we inject, and it will go to the organ of interest, and we study how that isotope is behaving in that organ during health and disease, and we use this information and which is happening at the molecular level, at the cellular level. Hence it is called as a molecular imaging.
So you mean to say through this technique we can detect a cancerous growth or any abnormal growth right at the early stage, maybe in an infantile stage, or maybe I can say that it is in the process of formation.
Yes, it is possible. But what happens in realistic practice? Patients will never come to you unless they have a problem. There is no concept called as preventive medicine in our country. They are all right, they will never seek any medical attention. Only when they develop something, then they will seek a medical attention, then the investigation start. So what happens usually, suppose there is a tumor seen, maybe patient comes to you with a cough. They usually take some antibiotics, it will not go. Then he may have a hemoptysis, and then the treating surgeon or a physician has some suspicion. Okay, it is not going, you do a chest X-ray. Chest X-ray, some lesion is seen, some shadow is seen in the lung. That is usually the first investigation. Any clinician will do. This is the bulk of the work anywhere across India. Then there is a suspicion, there is something seen. Then it may be tuberculosis in our country, maximum. It may be cancerous also. How do you differentiate? Then that battery of tests will start. So you do a CT scan, and there the radiologist will say some mass is seen, something is seen, maybe cancerous or maybe TB. Then you have to do a biopsy. Then it is confirmed, a bronchoscopy is done, they put a tube and you saw the bronchoscopy. Biopsy may be possible or may not be possible. It is confirmed histologically, pathology wise. Then they will confirm, okay, you have a cancer. Then the story does not end here. Now you have to see whether it is limited still to the lung or it has grown elsewhere. Then you will start advising. Most centers in the country, what they will do, you do a CT scan of the lung. Whether it is spread to the liver, do ultrasound of the liver, or MRI of the liver, or a CT scan of the liver, and they have likely to spread to the bone, so you do a bone scan. If he has some neurological deficits, maybe some shaking or some pain, some headache, then the clinician will doubt it might have spread to the brain, you do a brain scan. So the patient will be spending almost 10 days, 7 to 10 days,
minimum,
from center to center minimum, undergoing all the battery of different tests.
Yes.
And that 10 days is most agonizing for the patient.
Correct,
and
correct.
the patient near and dear ones, the relatives.
Yes, yes.
And each one may be throwing up different surprises, or contradicting results
earlier
or contradicting results or questionable results. So it may be adding lot of confusion.
Correct.
So what happens with this PET scan now, or a molecular imaging, one test we cover from head to foot. No need to do a separate test, all these things, a CT scan separately, because we cover whole body in one go, in 20 minutes flat. You have an answer. And you will diagnose the disease. Proper staging is possible, whether it is limited to the lung or it has spread elsewhere. The goal for every clinician is try to cure, because the moment the patient comes to you, the diagnosis is made, even, sir, is it curable? This is what they will ask. And in heart of heart, we will be knowing it has already spread. We always try to give them some comfort. No, it is still limited. Let us do all these tests. Based on that, I will be able to tell. So when you advise a battery of tests, it is an agony actually for us also as a treating doctors and also the patients. When they do this test, it avoids duplication of the test. Avoid all these tests, one after another, going from, because one particular test may be available in one center, or it may not be available in another diagnostic center. They have to go to other center. So it takes time. Money is also spent. So if you do this one test, it will save a lot of time and effort, money also, and you have a proper diagnosis. So it's most important in a cancer patient to have an accurate diagnosis, because we want to always try to cure. Earlier the better. Initial stage the better. You can always take out everything and do it. But what happens in the current scenario, when you do all these battery of tests separately, all the questions may not be answered, whether it is still localized or it has spread. With a PET scan, you have proper staging, stage 1, 2, 3, 4. Typically the patients talk, and I am also talking on the same patient terminology only. We as a clinician, we follow what is called a TNM staging. Based on this, the surgeon will be deciding. So when the proper staging is done, the surgery may be possible. And stage 1, stage 2, stage 3 or stage 4 will be beautifully answered by this molecular imaging. And as a treating surgeon, he wants a proper staging in one go. Very easy to do. We will be able to give the information. That is what we say, discover the power of molecular imaging. And today it is a rapidly growing imaging modality. It is a bit expensive, because the technology, that equipment, everything is expensive, and the way we do it is also very elaborate. It needs lot of infrastructure to develop it. Not every small city cannot have this. Usually they are in the bigger cities, and because of that, it is at present it is a bit expensive, but most of the patients are able to afford this test, and many patients are aware and they are demanding this test on their own, even before any surgeon or a treating doctor is asking, because lot of awareness is there in the media and also in the literature is available to the patients. And how we do this test, that's important. Most of the test patients whenever patient undergoes any test, there are a lot of anxiety, tension. They think because we are injecting a radioactive material, is it harmful for the patient?
Correct.
I would like to assure you, all of you, there is no radiation hazard. I told you in the beginning only, this is one of the most peaceful uses of radiation for the benefit of the mankind. So you need not worry about any radiation hazard. to the patient who undergoes this particular test. The amount of radiation we inject, radioactivity, is very minimal and it is very negligible. The patient need not worry at all. And we use also very judiciously this particular test. And how we do this test? We actually inject a radioactive glucose. So there is absolutely no reaction at all for the patient. Glucose
is body acceptable.
Is more, we survive on glucose.
Correct.
For every function of our organ, every tissue, every cell needs energy. It gets energy by glucose. So we all consume a lot of sugars, food, it all comes. The cancer tumors also need energy. And they are developing faster, rapidly dividing, growing, spreading. So they consume more glucose than the normal tissues in the body. So when we give this glucose, which is different glucose, which is radioactive glucose, they will not differentiate from what glucose we eat and what radioactive glucose I inject. So it goes to our whole body as well as to the tumor cells. The tumor cells are taking up this glucose more and they are very nicely seen in the scan. They are so nicely seen, it becomes difficult for us to appreciate that in regular CT scan and MRI scan. That's why many times though patients undergo CT scan, MRI scan, the questions are not answered. The tumor is there. The only thing is it may not be described or seen nicely by these imaging modalities. Whereas imaging modalities as molecular imaging, because it is taking up more glucose, it is very nicely seen. Any layman can very easily see, oh, it is here, 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 we come to know. And then it is correlated with a CT scan. It is a PET CT. So PET stands for positron emission tomography. Radioactive glucose emits what is called as the positrons. We see this radiation by an equipment which is similar to CT and MRI. It is called as positron emission tomography, like computerized tomography. We call it as positron emission tomography. And on the back of side of that, there is a CT gantry also. So you have a PET scan as well as a CT scan in under 20 minutes from head to foot. So you will see the glucose metabolism of the whole body. And wherever the tumor is there, because they are taking up more glucose, you are seeing that tumor very nicely. And when you see the whole body, you get an answer. Today, what happens most of the places, maybe for want of money or patients can't afford, they may advise only, you do only this test.
First we will see what is there.
What is this? But we fail to see whether, for example, let us assume a breast cancer for a woman. They may advise only mammogram, maybe chest X-ray. But what the effort has to be made, whether it has spread elsewhere in the body. If it has spread already elsewhere in the body, the surgeon may be planning a surgery. Surgery is a futile exercise because if it has spread elsewhere. So doing only regional investigation, only limited to one organ in a cancer situation is not advisable. When we do whole body, we are covering that particular organ of interest. Apart from that, whole body, so you get an answer. So you have a proper staging, and this is how it is done. We give radioactive glucose and the patient waits for 1 hour. We give this time for the whole body to consume the my radioactive glucose which we are given. The cancer cells will also take up and they are lighting up very nicely in the dark sky, like you see in the night, the stars very nicely at night. These cancer cells will be glowing in the PET scanner because they are showing more glucose uptake, and very beautifully you can see those things, and it is merged with the CT scan and you will get a PET CT and you have the answer, and this avoids duplication of the test. And immediately after the scan is over, the patient can go home. We usually give the report same day evening or next day, and it is usually read by 2 or 3 people, not only one. And it is usually read by a nuclear medicine specialist like me along with a radiology colleague. So we combine together and thrash out any issues. Suppose there are certain things which I will not be seeing nicely in the PET scan. It is covered by the CT scan. CT scan is seeing something which is not seen from the PET side. He will not be seeing anything. So we fuse both, they have an answer.